I'll go ahead and throw out the first question, which was really Uwe's question. I'm going to put Andrew and Pat right on the spot and say, he asked, will it scale up? You're both doing some really interesting things. Andrew, you've had a little bit more time to start the scaling up process. Why don't you each take a stab at that?
It's a great question, and it is important. And in fact, within operations research that we don't do enough of, as Uwe said, there's a growing science of scale that is of great interest to me. I actually think the scale answer was provided in the opening talk by CMS, because our payment model was, the alternative quality contract was written into the regulations that established the affordable accountable care organizations. And the goals and the velocity that's been established by Secretary Burwell and the administration on accountable care and payment reform, which is then causing the kind of delivery reform that we've seen in Massachusetts and then Pat is generating in Florida, I think is an example of scale. I think Uwe's other question is, are we just going back to Kaiser? I think there is an aspect of the kind of care we're promoting, which is integrated and less fragmented and involves physicians practicing more as a team. But I'd like to think that it also will allow some of the innovations that may not have been possible in the Kaiser system.
Nancy, let me make two comments. First of all, on behalf of everyone on the panel, I want to thank you for having Uwe be last. Because following him is not a fun thing. So thank you for that. Let me also say that I believe what we're trying to do will scale because what we try and do is have flexibility in our model. One of the things we ask from Washington is guidelines, not micromanagement, because all of my markets in Florida are different. I can't do it exactly the same way in each of those markets and think that it's going to scale. One of the Kaiser problems is thinking that because it worked in California, it'll work just the same in Washington, D.C. or somewhere else. And customers are the reason that Kaiser didn't scale. Customers weren't willing to go to that model when it went other places. Now, I think we have different market conditions right now because if you think about consumer choice, in the world most of us lived in, your employer made the decision about your health plan by selecting a health plan. And there was a lot of angst among some of the employees if they didn't get the health plan they wanted. The market is becoming much more of an individual market, or greater choice that employers are providing to their employees. And I think when individuals have the choice and they see the cost scale between the different options, they're willing to make decisions about, I'll take a narrower set of choices, or I'll take this particular set of providers, because I understand the value trade-off equation for my expense. That's different than when your employer makes that choice for you and you feel, alienated from the decision that was made. So there are different market conditions today, and I think that allows more of the Kaiser-type model to flourish again.
I'm going to go ahead and stick with one more question for the two of you because the questions seem... Oh, thank you. I'm going to ask Pat and Andrew another question because the questions seem to be divided between the two, and we'll give Uwe and Ovik a chance to recover from their presentations. So the question is, can Andrew Dreyfus and Pat Garrity talk about patient outcomes, please? i.e., do diabetes improve, or do diabetics improve, and are cancer patients living longer under your models?
Yeah.
From a national organization, no name.
Yeah. Well, I would say we have outcomes data on the quality measure, the things that we measure, and we do measure diabetic care, and diabetics are getting better in terms of the 4 or 5 standard measures that endocrinologists and primary care physicians use to measure outcomes of diabetic care. We don't yet have mortality data on that, and in the oncology area, that's an area where the measurement development is earlier in its life. But I have no doubt that based on the outcome data that we have seen, which is now over a 5 to 6 year period, that patients are healthier, and healthier patients are ultimately going to live longer.
Yeah, similar to Andrew, we're seeing results that are headed in the right direction, but it's early. These are early to make full-time conclusions. But what I will say is on the oncology side, we created 2 cancer oncology ACOs in Florida. And I think they were the first of their type that were specific, disease-specific. And one of those with Moffitt Cancer Center. And so what we're trying to do is drive patients to the very best facilities. If you think about how cancer is handled in the country, nearly every hospital is trying to manage it, and yet there are clear centers of excellence. And so we're trying to make sure that where we have the opportunity to drive to a center of excellence that handles the type of volume, that has the expertise, that we're giving our patients, our members, the chance to get their care at the very best facilities.
All right, here is a question from somebody at a federal agency. What is the role of provider competition or consolidation in the transition to value-based alternative payment models? Many providers argue they must merge together to have the scale and resources and clinical integration necessary to achieve this transition. Is this accurate, or will competition actually drive the triple aim of healthcare reform?
Yeah, I'd say that integration, we believe, is necessary to provide the kind of care that I think a lot of us have talked about today. Thank you. But that integration does not imply that it has to be ownership, shared ownership. So you can have so-called virtual integration. And we have some of our highest performing groups are smaller practices that are affiliated with 1 or 2 hospitals that are not owned practices. And so integration, we think, is a condition, but ownership is not necessarily.
Yeah, the one comment I'd make in this space, Nancy, is that we bought a multi-specialty practice just outside of Tampa, Florida, the highest quality practice in that area. And the interesting part was their 2 main suitors were both hospital systems. The lead doctors came to us and said, we'd like you guys to be in this process, because if we're bought by either one of these hospital systems, we know we will have to compromise our approach to medicine and admit more patients than we think is right. And so we got in that mix because we wanted to learn, we thought this was the right partner, and they made a compelling case about how they would be compromised to admit a patient if they were in fact owned by the hospital. And so I think every patient out there ought to be thinking about, if that practice is owned by the hospital, are you getting that doctor's best and most objective opinion about whether you should be hospitalized?
Okay, now let's switch over to Ovik and Uwe. Question from somebody at a national organization. With all the buzz on drug pricing transparency, especially in California, how do you think this will affect the industry? Will it ever pass? Is collaborative transparency the direction we should be moving?
I think transparency will help, but I'm not sure how much it will help in the sense that, you know, some of the transparency proposals have been around, well, drug companies should be able to list why they think this price is the right price. Well, that's not, you know, why somebody thinks the right price is the right price isn't how things work in a normal market. Consumers actually decide whether the price is an appropriate deliverer of value, or insurance companies in the case of third-party payment of health care. So yes, transparency can help, but pharmaceutical companies already publish pharmacoeconomic studies that are supposed to demonstrate, say, if a new drug comes along, how much it reduces the length of stay in a hospital and how much money, therefore, the system saves from doing so. And typically, those pharmacoeconomic studies show that the drug actually will cost more in terms of the total cost of care relative to what was being saved in the system from lower hospitalizations and things like that. So transparency alone, I don't think, is the issue. I think the real issue is we need to have more competition because competition is what leads to pricing signals that actually matter to patients and insurance companies.
Do you want to comment on it, Uwe? Transparency.
Yes, this issue of price transparency, not only in drugs but in other areas of healthcare, one shouldn't oversell it. Martin Gaynor, who worked as an economist worked at the FTC was clear in pointing that out, and it is what Ovik says. If you have a non-competitive market, a monopolist market, price transparency doesn't help you at all. You still have very high prices. So you do need some form of competition. And very often, actually, in the pharmaceutical industry, it does actually come in the form of Me Too products. I mean, there's a lot of people who are down on Me Too products. I've never been so down on it because Me Too products can, in fact, exert that competition, which we have seen in the case of Solvati. The other problem of price transparency is in the US, there isn't one price for anything. It just varies by insurance company, by product sometimes. I once asked it was Blue Cross New Jersey, I asked, what do you pay for a colonoscopy? And the CEO told me, well, actually probably have 50 different prices. So then the question is, what price do you actually reveal to people? So price transparency is a good thing. Costs are difficult in pharmaceutical industry for the reason that both of us mentioned. If you just look at the cost of making that drug, the clinical trials, et cetera, that's only a part of it. You would then have to add all the dry holds plus the opportunity cost, and to make people understand what these costs are. Experts, yes, maybe, but forget lay people. Most lay people cannot read the income statement of any company and understand it reasonably so. I mean, that's why God created accountants, right? But I'm not sure what you actually get from asking for cost information on it. If you get it, you'll get all kinds of information that may or may not be valid. Be very hard to audit.
It might help more with physician and hospital service, but I think with drugs, we actually have a reasonable amount of information about how drugs are priced. The problem is the lack of competition and the high barriers to entry.
Okay. I'll throw out one more, and I shouldn't restrict these questions. I'm just, any panelist can jump in, of course. So do you see tools such as Peter Bach's Drug Abacus, the ASCO Value Framework, or NCCN's Value Matrix ultimately affecting drug prices?
Not really. To a degree, they can perhaps help insofar as if there is a perception, a PR perception that a drug is too costly. That is something that larger companies in particular pay attention to, because if you're a large company with 20 drugs on the market, another 20 or 30 or 50 in development, you're not going to always be super aggressive on one drug because you know that might have policy and political ramifications for your entire portfolio. Whereas in the case of someone, a more entrepreneurial setting like a Martin Shkreli at Turing, he's got one drug, and if that drug is successful, he's going to do very well economically because of his equity stake in the company. So these kinds of metrics can help, but they also don't necessarily give you a real expression of value. The only true expression of value is a true system where the consumers and patients and insurance companies can compete and deliver pricing signals. I'll give you a classic example from the UK. So the UK, as many of you know, has this agency called NICE, the National Institute for Clinical Excellence, and they use these things that economists like called quality-adjusted life years to assess, okay, well, does this drug cost more than £20,000 sterling in quality-adjusted life years? If it doesn't, if it exceeds that, we won't recommend reimbursement for it. And a lot of people in Washington agencies and in academic settings think that's really beautiful. The problem is it leads you sometimes to some funny situations. So many years ago, about 10 years ago, NICE was trying to figure out whether to reimburse for Lucentis, a drug developed by Genentech, one of the pioneers of the biotech industry, that treats one of the leading causes of blindness in the elderly, age-related macular degeneration. And because the drug was expensive, NICE decided that they would reimburse for the drug if you were already blind in one eye, but not if you could see from both of your eyes. The idea being, if you could see in both your eyes and you went blind in one eye, that was not a big deal because you still had another eye and you could still see. Whereas if you only had one eye and you lost a vision in that eye, then you'd be totally blind. That would be bad. So NICE decided we'll pay for Lucentis to treat people who are already blind in one eye, but we won't pay for it to treat people who can see in both eyes and are at risk of losing sight in one of their eyes. Now, you can understand why the average person in the UK thought that was completely ridiculous. Nobody wants to lose sight in either of their eyes, and frankly, it is clinically important to have sight in both your eyes, because when you can only see through one of your eyes, you lose depth perception, and you can have a lot of risks of accidents and falls and things like that. And so when a bunch of people like Uwe are sitting around in a room making these kinds of decisions as to, and I love you, Uwe, but, when they're making these decisions in a room, they're not always thinking about what the patient actually wants. And in that case, the patient might have actually said, you know what, I know it doesn't look like that drug is delivering value, but I actually do want to see it both my eyes, and I'm willing to pay for that. And maybe some of the other things you think I should be willing to pay for, I wouldn't be. But consumers don't have the opportunity to deliver those price signals to the market.
I think we all want to get him in this one.
Here he comes.
Before Uwe responds, the one thing I'd say, a different answer to the question, is that the public debate about spending on pharmaceuticals has been mostly this debate that you've heard replicated a little bit around regulation versus competition and the role of the FDA. But what I'd say about the work that ASCO is doing is that it's bringing the voice of the clinician to the debate, which has been largely absent. And by raising questions about the relationship between the price and efficacy of drugs, which is what that group is doing, that's making a really important contribution to the debate. And I think the American public will not simply be looking from signals, frankly, from health plan executives or celebrated economists like we have here today, but from their clinicians. So I think it's going to add a lot to the debate.
Go ahead.
On the issue of, I noticed your English that you were using, that I value this, right? So if a Donald Trump were to ask, how do you value this? He'd put a different bid price on this than a waitress making $25,000 could put on it. And then many economists, I will say, would say, well, the waitress doesn't value it as much, which is kind of a misuse of English, because the word to value also means to appreciate. She appreciates it just as much. So ultimately, you then ask, do you want to distribute Lucentis on the basis of price and ability to pay, the way we do Coca-Cola or French wines? We could do this, and an economist cannot second-guess this. It's an ideological view. Or would you like everyone to have access to this product? And if you say the latter, it becomes a collective decision. You can't avoid it. It becomes collective, because then you're asking me, how much am I willing to pay for someone else whom I don't know, may not even like if I did know them, to get this treatment. And therefore, to argue that the market can solve this, that these do not become political questions, it doesn't make sense to me. They are collective decisions that you have to make. Now, the Brits made that decision, realized the populace didn't like it, and I'm sure NICE relented. We have an expert of NICE actually sitting right in front of us. She's a consultant, an advisor to NICE. They relent when they see popular pressure on that. But that is the difficulty that I was alluding to say, we do not know in America what value to put on a quality-adjusted life year. The Brits sort of do it, but they relent when the pressure is there. The Germans do it, the Australians do it. We don't want to discuss it. This Congress won't even allow costs to be entered in cost-effectiveness analysis. Congress hates cost-effectiveness analysis because it might implicitly put a value on human life. That's how shy we are about this. So this is a larger issue than to say what I would be willing to pay for a drug. It always turns out, clearly in the case of Solvati, when you see the people who actually get this drug, often are on public programs or in jail, it becomes a collective decision. And at some point, our students, our kids will have to come to terms with it. I think we can, for a couple of years, still sweep it under the rug. But what you would not catch me do is to say, yes, we should cover it, and yes, we should pay a high price, and we should cut social spending and lower taxes. That would not happen to me, that I can guarantee.
So I did want to comment on this as well, but I didn't want Uwe to explode waiting to get his answer out. So let me just make a couple of comments about pharmaceutical pricing, a couple of things. First of all, the margin on pharmaceuticals around the world is a fraction of what it is in the United States. We should be asking a question about that. Why do we pay so much more than everybody else? And are we willing to fund the world's innovation and research and development? There's a question there. I went on a delegation trip when I was in Minnesota to Germany, and the gentleman in charge of pharmaceutical purchase in Germany asked us, why do you allow for pharmaceuticals to be advertised on television? Have anyone seen the chart that shows U.S. pharma spending from before we had advertising on TV to after we had advertising on TV? It's a straight-up bar. And so you have to ask about efficacy when, in fact, when we went direct to the consumer, it exploded in terms of what we spend on pharma. So we're one of the most nations in the world that is spending on pharma, and yet our outcomes and our health levels are nowhere near where they are a lot of other places. So there are some very, very baseline questions that we need to ask about whether or not we're willing to fund the world on this, and the fact that we restrict ourselves from the government standpoint for negotiating with pharma is something that it continues to amaze me. It doesn't get more attention in the press. It doesn't get more debate in Washington, D.C. The largest purchaser of pharmaceuticals doesn't get to negotiate the price. It's absurd.
The question is from a congressional office. Most insurance companies offer price tools so policyholders know the price and quality before they visit a provider, but only about 2% of people use them. How are you motivating your policyholders to shop for health care? And we'll make this the last question.
Yeah, I'll answer quickly, and then I'm actually going to slip out the side because I have a plane to catch. In Massachusetts, we're required to make that information available to our members, and the key barrier traditionally has been you can tell someone the price of a procedure. Uwe talked about the price of a colonoscopy, but could you tell them what their price would be given their policy and their co-payments and their deductible and their co-insurance? We now have the ability to do that, and we're making that available both on mobile tools, through our website, and through phone calls. And so the question is right. The take-up is still low, but it's starting to grow.
Yeah, I would completely agree with Andrew, and I think I cited that example in my comments earlier, that we are encouraging that. We use our retail centers to encourage that, and it's certainly available through our website. The take-up has been not as strong as we would like it to be, but it is better than the national numbers, and we're seeing a trend in that direction.
Great.
If I can add just one comment, I think the biggest reason why consumers don't use these tools is because they don't actually save any money if they actually use a less expensive hospital. By and large, the economic incentive isn't there for the patient. And that's a big part of also what drives hospital consolidation, something you brought up earlier, which I once wrote a piece for Forbes where I described hospital consolidation or hospital monopolies as the biggest problem in healthcare that nobody talks about, because it does restrict competition and the ability of insurers and patients to direct their business to the hospitals that are delivering the highest quality, lowest cost care. So this is a huge problem that we have to do more to address, and that involves, I think, two different lanes. One is antitrust and competition and reducing the barriers to entry for new hospitals and new doctors to get into the game. And on the other side, we have to give more opportunities to patients to choose the insurance plan that delivers the best value to them, because in that way, the insurance company has the incentive to make sure that they're holding hospitals accountable for the quality and value and price of that care.
Well, there's also a fallacy that if it costs more, it's higher quality. We as a people believe the more expensive medical service is better, and the data does not bear that out at all. Yeah.
Actually, on that point, and Andrew is gone, but the Massachusetts they publish a cost report every year, and it actually turns out that the drift has been towards more expensive facilities. In other words, they do have these prices Andrew talked about, but in fact, rather than what you would expect, people now know the prices, and they gravitate towards the cheaper, less costly facilities. It was the opposite from that. The other thing I was going to ask both of you, but now ask you, Patrick, are these binding prices or are they what was in the past? In other words, if I go to a doctor that I thought was low cost, am I guaranteed to get low cost, or are they in some sense binding, or what am I looking at?
Today, they're estimates within a range and based on history. So it's not an absolute contract, but it gets you within a pretty close proximity of the obligation.
Yeah, maybe their popularity will grow over time. It's still quite new, this too.
All right, let's make that the last word, and I'd like to thank our panelists, and let's have a final round of applause for them.